trouble, man. Start
What's that?
the seminar on time. Come on.
It's not that, so that you are involved.
Okay.
So we are on time. We'll start off. We are live, Mr. Sriram.
Yes, we are live. That's what
Okay.
the chat box.
So it's 7:30 also. So we'll start with the third OSCE exam, and then the exam is on coming Friday, 26th. So I wish best of luck to all the students. But then a lot of people who not appear their MCH also, I think part of their exam also will follow this OSCE pattern. And many of them have, as I know that NIMS will have in the end of the month, and many students all over the country will have exams. So I wish best of luck to all of them. And with these few words, I'd like to start off the program. Every time, I request all of you to take a pen and paper, practice writing down the answer, because that's what you have to do in your exam. So write it means practice how to write neatly and in a short time, and giving all the points. And I request Dr. Anita to first start off his sets of questions. Each examiner has 20 minutes and 25 questions, 20 to 25 minutes of both questions and teaching and testing session. So, Mr. Sriram, can you please share the slides of Dr. Anita?
Yeah, thank you, Dr. Manas. And so, can you run in slideshow, please? This is, yeah. Next slide, please. Yeah, this is the CT angiogram of a patient. And what is the diagnosis? What can be the presentation of this case? Next question is, what are the different modalities of cerebral angiography? And one feature to differentiate between them. 3 minutes for this. Start the timer, please. Yeah.
Yeah, if they are done, you can ask, and then you can.
Okay.
You don't have to wait for 3 minutes. If the
Okay,
students
Amit,
have
is it
done.
done?
Yes, madam.
Amit, Sriram, can we move on to the next slide? If few people have done?
Done, madam.
Yes. Yeah, then Mr. Sriram, we can move on to the answer slide.
No,
So we need to ask them the answer, or they'll give the answers, or I just need to say tell
You
the
have to
answer?
ask them, ma'am. You have to ask them to
Okay.
ask.
Yeah, we can go back. So what is the diagnosis?
Diagnosis is, madam, left MCA bifurcation aneurysm showing, madam, multiple.
left MCA only, you said?
Left MCA and with vasospasm. Left MCA
So
vasospasm.
this is the ICA, this is CT angiogram, this is internal carotid artery, and here it is bifurcating. This is anterior artery, this is middle cerebral artery. So you are seeing some outpouching here also. So you missed this. So this is a case of multiple aneurysm, left ICA bifurcation and left MCA bifurcation. Single, it's not single, it is multiple aneurysm, and one aneurysm at both the sides with the MCA vasospasm. You were right. So what can be the presentation of this case? What clicks to your mind?
Patient mostly present with right-sided hemiparesis or hemiplegia and aphasia, and other is if it bleed, then headache, severe sudden headache, vomitings, and loss of consciousness, and contralateral hemianopia may also present if it bleed into the
Seizure too. Seizure can also present with seizure.
Yes.
Right, that's true. Good. So you can write in this way that what all can be the presentation, like subarachnoid hemorrhage like presentation, hematoma like presentation, neurological presentation because of the vasospasm, the ischemic presentation. The ischemic presentation may include hemiparesis, hemiplegia, aphasia, even the seizure is one of the can come into the ischemic as well as in the electrolyte imbalance. So next is, what are the different modalities of angiography? You know,
we can do CT angio, CT scan angio contrast, and MR angio either contrast or non-contrast. In non-contrast, we can do time of flight and phase contrast.
Right.
And then 4-vessel angiography. It is called DSA. Gold standard for the aneurysm, whether therapeutic and diagnostic both. And
you know something intraoperative?
Intraoperative ICG.
Yeah, ICG video angiography.
Yes,
so
video
can we move and can you differentiate? How can you differentiate? Suppose 4 images are given to you, and you are not told that what is this, what image. Can you differentiate which image is what?
This is CT angiography, madam.
How did you say that this is CT angiography?
Because
why not it is DSA?
Different. DSA, we can give a dye and see the flow, the live image, and
live image. If you are running the image, if you are taking the video, you will show the live image. But if you have taken the snapshot or a picture of the running image, then it won't be live. Of course, you're right. It is a live image. So can we move on to the next slide for answers, please? So as you said, this was the diagnosis, very correctly said, and this will be the presentation, both SH-like presentation, hematoma, can be temporal hematoma, can present as a basal ganglia bleed. So these patients are mistaken as basal ganglia bleed, but here the blood will start from the fissure and then will go up and may reach to the basal ganglia area. Then ischemic, again, what all we described, and combination of all can be there. Next slide, please. So these are the 4 different modalities: CT angiography, MR angiography, digital subtraction angiography, and ICG indocyanine green video angiography. So these 2 images, you see, these images will show all the vessels in one picture, both MR angio and CT angio. As you can see, all the vessels, all 4, 5, 6 vessels seeing in one image, one cut. Whereas in DSA, you see, because it is selective angiography, it is selective, it is dynamic, both dynamic as well as selective. So you will see only one vessel at a time in one film. In one cut, you will see only one vessel. Like this is internal carotid angiogram. Then you will see vertebral angiogram. Then you will see external carotid angiogram. Like this, you will see different images because it is selective. It can be super selective, that only you can see, you are seeing only the MCA, you are seeing only the ACA, you are seeing only the PCA, depending upon in which vessel your catheter is going. In ICG video angiography, this is also dynamic, but you will see the area of interest which is under your microscope, not all the vessels. Then you can see all the phases of angiography, that is arterial, venous, capillaries, everything can be seen, and you will see the spilling of the dye in the surrounding area where you are seeing the blood. That is also there. In MR angiography and CT angiography, you should always ask for the base image, because you are seeing the bony cut. Sometimes they are very confusing, MR and CT angiography, which image is what. But one is the bony window. You should see the basal cut. You'll get to see the bones in CT angiography, whereas in MR angio, you'll see the gray scale of the MRI. Right? It's clear?
Yes, ma'am.
And we can move on to the next question. So this whole is based on the vascular actually. So what is the final diagnosis by seeing these images, different planes? What are the features or modalities to assess which aneurysm has bled in multiple aneurysm? Features or modalities, and in which cut angiographic Sylvian point is seen? Which cut of the DSA or angiogram? Which cut means which plane? Coronal, sagittal, axial, which plane? Can start the timer, please. When you are done, Amit, please let me know.
You finished answering, Dr. Krishna? Any one of you?
Krishna,
Only
Debnath.
only one
Harsh.
question is visible, ma'am. Only one question is visible in the screen. In which cut angiographic Sylvian point is seen? Other questions are not visible.
Achha, okay, what is the final diagnosis? If you are seeing the other pictures?
Yes, ma'am.
What is the final diagnosis? And other question is, what are the features or modalities which will say that, okay, this aneurysm has bled among many aneurysms?
There are multiple aneurysm. Number one is at the ACOM, and
Right.
another is at the right MCA bifurcation, and
Right.
one is at the left ICA bifurcation,
Right.
and other one, I think, ma'am, it's not clear to me. I think it's left MCA bifurcation is also there one.
Yeah, okay, this is right side. This is right side.
Yes, ma'am.
And this is left side.
Yes,
So
ma'am.
you are seeing right ICA bifurcation. So this is right side. That means this is the side, because you need to orient yourself with different cuts of the CT angiography. It's not one cut which can tell you all the details. So you have to see that in 3-dimensional or 4-dimensional images. And this is right side. You can see my cursor mouse, no?
No,
ma'am.
Now
It's
we
not
are seeing.
visible.
Now it's visible, madam.
It is
Madam,
visible.
I am projecting from my screen. So
Okay,
when
you can do the here, na? Can you take it from here to this place?
where to the bottom, or you can say right or left of the screen, ma'am.
Okay, the left side of the screen is showing the bifurcation aneurysm,
Yes, ma'am.
and this is bifurcation. Sorry, uh, right side of the screen. This is right side. On
Yes.
your left is the right side, right? So this is bifurcation. Anyway, don't confuse with right and left. It's okay. One is ICA bifurcation, one is MCA bifurcation, one is NTA communicating, and you can see that at the basilar top, where you can see the superior cerebral and posterior cerebral artery, there is dilatation, pouching, out pouching. Can you appreciate that?
Yes, ma'am.
So it's not that you just need to see the ICA territory. You need to see the whole, each and every single vessel of the angiogram to comment what it is. But there is, of course, there is no vasospasm. I have no evident vasospasm by seeing this CT angiogram. So, right, what are the features or modalities to assess which aneurysm has bled in multiple aneurysms?
There are, ma'am, multiple points which will look. Number one, if there is irregular margin of the aneurysm, if there is associated lapse, if there is extravasation of dye, vasospasm of the adjacent means parent vessel, if there is a big size aneurysm usually bleed among all the, and if there is change in the morphology from the previous one to the latest one. These all are the points which will look.
These are the morphological features you described. Can you say, name any modality which will tell you, okay, among all these aneurysms, this must have bled?
Vasospasm?
Any modality, any imaging technique. Anyway, in which plane you will see the angiographic Sylvian point? Which plane? Axial plane, coronal plane, sagittal plane. On which plane you comment?
Axial and coronal both.
Great, very good. So we can move on to the next slide of answers. How can I show them? Because I need to show the mouse frequently. I need to point out the things. How can I show it, Mr. Sriram?
You will have to project it from yours. Otherwise,
can I use the pencil?
No, you have to share your screen and do it.
Otherwise, I cannot do.
Otherwise,
yes,
yeah.
Because I have not put arrows at every place. I thought I'll show it with my mouse. So anyway, if it is not visible, I'll ask Dr. Manas to show it, please. Huh?
I also cannot do.
You cannot also do.
Yeah, because only Sriram is projecting the slides.
Okay, let's see. So what the final diagnosis is correctly told. Then features or modalities along with the morphological features. We have one vessel wall imaging. This is the technique. It is a MR angiography technique.
Hello, madam. Probably you can annotate. You can, I don't know, Sriram, if you have enabled that feature. Annotate you can do, and you can make some mark over there in your slide where you want to show.
But annotation is not visible on this. There's nothing, no option of annotation on this Zoom.
It should be there, Sriram. That is disabled, huh?
Again, she can only see it on her screen when she.
On your screen. Yeah, on your screen you will see on the top right options. You click, you will find that the lower down annotate is there. There you can choose a cursor and then make some marks.
Yeah, is it my presentation visible now?
Yes.
Yeah, okay, this is fine now. Then this is...
Go to slideshow, ma'am. Slideshow, please.
Slideshow, okay. Yeah, so this is vessel wall imaging technique in which we fuse three things. It is MR angiography. It's a sequence of MR angiography which can be done with 3 Tesla. And we fuse 3 images, that is TOF MR angiogram, vessel wall imaging, and you give the contrast also. So here the blood is appearing black. My mouse is visible now.
Yes,
madam.
Yeah, this blood appears black, and the wall that enhances. So the aneurysm which has bled, there will be vasa vasorum and all, increased vasa vasorum, wall is inflamed, so it will take up the contrast, and this wall will be enhancing in multiple aneurysm. So this is the slide which I have taken from a journal, and here they have seen that this was the point of bleeding intraop, which is matching with the site which was shown on the vessel wall imaging. So this is a technique which this is the imaging sequence of MRI which can differentiate many pathologies like vasculitis. and aneurysms, vasculitis, and many atherosclerosis, and even the plaque also can be seen by this image, this vessel wall imaging. Then next question is, can we move on to the next question? It's clear? It's clear now, Krishna?
No, the
Krishna.
third
Third
answer
question is, yeah,
is
that is, you were right that it can be seen both in coronal and axial curves, the Sylvian point, and it denotes the medial most part of the temporoparietal artery, the medial most part. This is the area where it represents. This area represents the posterior limit of insula. Although it is obsolete nowadays, no one looks for the this point in this era when we have MRA and all. But previously, it used to tell us that there is any mass in the retro insular area or not. So moving on to the next question. I think there is no timer in this, but we can go because I can use with my mouse. These are the aneurysms. And suppose you are clipping this aneurysm, that is IC aneurysm, MC aneurysm, ACOM, and PCOM. Suppose you have all the aneurysms in one case. So what all spaces, CSF spaces, you would like to open to clip all the aneurysms? Then what is the membrane of Liljeqvist? Next question is, what are the segments of Sylvian fissure and content? I'm switching on my mobile's timer. Is it okay?
Yeah, it's okay. Dr. Harsh, if you are ready, you should tell so that she will ask you. Put on your audio here.
Okay, sir. Okay, sir.
Are you done or?
Harsh, is it done? Are you done with it? Anyone?
Yes, ma'am.
Can we move on to the answers, please? First question, clipping of ICA, MC, ACOM, ICA, PCOM would require opening of what all CSF spaces? Name few.
No, okay, the clipping of IC aneurysm will require us to open the Sylvian system. And MC also can be clipped via the same system. And if we want to clip the ACOM aneurysm, then we have to open the interhemispheric, we have to enter the interhemispheric system. And sometimes we have to open the lamina terminalis system.
Right. Okay. What is membrane of Liljeqvist?
Madam, the membrane of Liljeqvist is an arachnoidal band which generally separates the chiasmatic system from the interpeduncular system.
Shall we move on to the next question or want to add something?
No, ma'am, that's it.
Okay. Can you name the different segments of the Sylvian fissure and contents also?
The segments are the horizontal segment and the vertical segment. Contents, I
What-
am not sure.
You can, what you normally open, you don't see the horizontal and vertical segment. They are more of theoretical, like what you see there, and they are more visible, better visible in the CT or MRI.
The
Intraoperative.
proximal and the distal.
Sphenoidal, insular, opercular, and
Good.
that one.
Right. And can you name the contents?
Contents, I am not sure.
Anyone want to add, or shall we move on to the answers?
Content is, madam, all the branches of MCA along with superficial middle cerebral veins. And
okay, so we move on to the answer. As you correctly said, that Sylvian fissure has to be opened. This is Sylvian fissure. You can see the ACA here, MCA here. So MCA is visible once you open the Sylvian fissure, right? But for ICA PCOM, MCA will take you to the internal carotid artery. So you have to open the carotid cistern, otherwise you cannot clip the PCOM. So you open the Sylvian fissure, then this is optic nerve, and this is carotid artery. So to reach to the anti-communicating artery cistern, to the anti-communicating aneurysm, that is interhemispheric cistern, you need to open the optic cistern, otherwise you cannot reach to this place. So once you open the Sylvian fissure, then optic cistern, carotid cistern, opticocarotid space, and then you're opening the interoptic cistern. This is one optic nerve, ipsilateral, contralateral optic nerve. You will open this interoptic space also. As you correctly said, the lamina terminalis, this is optic chiasma, and behind the optic chiasma is lamina terminalis, and interhemispheric fissure, of course. Then coming on to the segments of Sylvian fissure. So first is it is divided into actually three parts. One, you can say fourth part also, the cortical part also. The medial most part is the velicular sphenoidal part. Middle part is insular part, and then retroinsular and the cortical. You can say cortical, or you can include it into the retroinsular part only. So this velicular part is the most difficult part to open, because here the arachnoid is very tight. You must have seen during the dissection. This is over the planum pole, and it contains ICA bifurcation. Look, it's not only MCA which is there in the Sylvian fissure. The ICA bifurcation is also buried there. Lateral lenticulostriate perforators, proximal MCA, and deep Sylvian vein is the medial part of the fissure. You can see this is very tight fissure here. Then second part is the middle part insular, which is the most wide fissure, most wider part, biggest part, longest part, 6 to 7 centimeter long. It overlies from, it extends from Lyman insulae to the posterior insular point. And MCA bifurcates here. You see, MCA bifurcates and start giving branches, maybe early branches, maybe delayed branches. So branches which are supplying the area, like we all know that there are 12 branches of the MCA. The branches which are supplying this part and this part, that is temporal part and the frontal part, they'll arise early. So they will be there in this insular part, right? So all the frontal branches, 2 frontal, 2 central, precentral, central, temporal polar, and middle polar, posterior temporal, these all will be there in this part. So in this, from the insular part. Then retroinsular part, again, you have the tight arachnoid. It's difficult to open these two, the medial most part and the lateral most part of the fissure. This is 4 to 5 centimeter long. It covers the supramarginal, transverse, all the gyri here located. That is supramarginal, temporal. Sorry. Can we move on?
Yeah. After
Anyway,
his answer, we want to talk to Balamurugan because we have finished 30 minutes.
Okay, fine. So, Liliquis membrane, you see, you said correctly that Liliquis membrane is a arachnoid membrane. There are 3 types of arachnoid membrane: convex, basal, and trabecular. Liliquis membrane is the trabecular type of arachnoid membrane. It has got 3 separate leaves. One is diencephalic leaf. This is diencephalic. This is mesencephalic leaf, and they can be both diencephalic, mesencephalic leaf. This separates not only chiasmatic and prepontine, it separates the interpeduncular cistern also. Interpeduncular, chiasmatic, and prepontine cistern. So when we are opening the, we are clipping the acoustic communicating artery, we are opening the diencephalic part of the lamina terminalis, this part. And when we are doing ETV, we we are opening the mesencephalic segment of the liliquis. So multiple layers of arachnoid and all, actually they are multiple layers of liliquis membrane. Froelich and Zhang has classified them based upon the whether there's diencephalic, whether it is mesencephalic, whether they are single, whether they are splitting, and actually its origin is from the dorsum segment. So I think that is enough for you.
Yeah, thank you, Dr. Anita. And but if we have time, we'll go through the rest of the questions in the last. And now I request Dr. Balamurugan from Senior Consultant at Apollo Chennai Hospital to conduct his test.
Madam, can you stop sharing?
Yeah, there.
Sir, you're muted.
I stopped sharing.
Yeah, Dr. Balamurugan to share his screen, please.
Yeah, thank you, Dr. Manas. Thank you, Dr. Muthukumar and Dr. Suresh Nair for this opportunity. So I'll just be doing a short presentation and questioning. It will be based on one clinical sign and one case history and the management of that particular case, the surgical aspect, and the instrumentation required for that particular surgical case. That's the pattern which will follow. So the first three questions I would like Dr. Krushna ji to take. Is Krishna there? Hello? The candidate Krishna is there?
Yeah, he's there.
Okay. This question is for him. It's 1 minute. Please have a look at the short video.
Sir, can you go to slideshow, sir?
Okay, you need it on the slideshow. Okay. Okay. Is it on the slideshow there?
Yeah.
Yes.
Okay. Please have a look at this video and take 1 minute, and then we will discuss the next question. I'll play it out again.
Yeah, you can ask them to.
If you're ready, we'll go to the next question. Dr. Krishna.
Dr. Krishna,
Hello.
Yeah, if you're ready, we'll go to the next question.
Yes, sir. It appears to be right lateral rectus palsy, sir.
Right lateral rectus palsy. Excellent. Okay. So the next question is again for you. What are the other clinical tests you would want to do for this patient to ascertain it and also to evaluate the amount of disability that this patient has? So again, I'll repeat the question. So I agree with your diagnosis of a right lateral rectus palsy. What are the other clinical tests that you would want to do on this patient so that you can ascertain and quantify the amount of problem this patient has? Your time starts now.
So should I speak it or?
Sorry?
It remains. I would like to go for cranial.
I would like you to write it down. Think over it. Write
Okay,
it down. Take 1 minute. Okay. When you're ready, you tell me. Then we will next one.
Okay. Yes, sir. Ready?
Okay, you're ready. Okay, just hold on. We'll see the next one also. And then the 3 questions are for you. And then I'll move on to the next person. So this is a representation of the photograph of this base of skull. And I have marked out a few points which you will need to name those foramen there. Okay?
Yes, sir.
Those foramen. The one on the right, on the left-hand side, this one is actually should be here. Okay? This
Okay.
be here, right? So I want you to name this foramen, this foramen, this foramen, and this one. Okay?
Yes,
If you're able to do this also, that'll be excellent. And this is the 6th nerve which is coursing there, just for your observation. And on this, I want you to identify the 3 structures. The structure this structure, and this structure. Okay? You can take 2 minutes.
If the left, right hand side image is same as the left one, means it's
This image and this image are 2 different images. This is only a bony image. This one has some soft tissue, and the parietal dura is still there. Okay, so this contains some soft tissue. So I want you to name this soft tissue. I want you to name this structure which is passing through it, and this structure which is passing through another foramen there. Here I want you to name the foramen in the bone. Okay, one here, one here, one here, and this arrow alone is slightly moved. It actually should be here. Okay, so your time starts now. If you finish earlier, please tell us so that it will give us a little more time for discussion.
yes, sir.
Okay, excellent. Okay, right. So this we will come to it a little later. Now, may I request Dr. Debnath?
Yes, sir.
Dr. Debnath?
Yes, sir.
Yeah, the next 3 questions are for you. The same, it is based on the same video which I had put first. Okay?
Yes, sir.
Read that it was a lateral rectus palsy. The lateral rectus muscle is supplied by the abducens nerve. So I would request you to please name the segments of the abducens nerve. Anatomically, into how many segments is the abducens nerve divided? Please name the segments of the abducens nerve. You have 1 minute, starting now. If you finish earlier, please tell me.
Yes, sir.
Okay, very good. So the next question is again for you. Name the 3 syndromes, 2 medical and 1 surgical preferably, associated with abducens nerve. Okay, your choice. 2 medical syndromes which you heard about or you have seen in the wards, and 1 surgical syndrome associated with abducens nerve palsy. Okay, you understood the question?
Yes, sir.
Yeah, you have 1 minute. If you finish, you let me know, we'll move forward. Sriram has been very enthusiastic.
Yes, sir.
Okay.
Yes, sir.
Right. So the last question to you: how do you manage diplopia, which is caused by the abducens nerve palsy? So this patient would have presented with diplopia. how will you manage the diplopia? What are the measures you will take to reduce the disability that the patient is going to face and also help in the recovery? Okay. So how do you manage diplopia due to abducens nerve palsy? Your time starts now. You have 1 minute.
Yes, sir.
Excellent. Okay. So if you're all ready, let's go into the discussion part of it. Okay. Right. So the diagnosis, as you said, Dr. Krishna, it is an abducens nerve palsy, sixth nerve palsy. Now, what are the other clinical tests you want to do? Dr. Krishna, can you please respond?
Sir, I would like to do overall neurological examination. Other than that, specifically, sir, fifth cranial nerve, seventh cranial nerve, eighth cranial nerve initially, followed by third and fourth cranial nerve, sir.
Okay. Now, the question was pretty specific. I asked you, what would the test be to assess and quantify the problems that the patient will have? That is, in relation to the sixth nerve palsy, what other tests would you do? I agree that you will be examining the rest of the central nervous system, the other cranial nerves and other things. But for sixth nerve palsy, what are the two other tests which you will do? Clinical tests, which you can do on the bedside. But it involves a few other things. Anybody else? Dr. Debnath?
Cover test and diplopia charting, sir.
Cover test is one. The other one, please.
Diplopia charting.
Diplopia charting. Very good. Excellent. Okay. Anybody else? Dr.
Yes.
Anything else that you would like to add on?
Yes, sir. I will tell, sir. Either red lens or Maddox rod test. You can do bedside.
So you can do the Hess chart, which will give us the exact movements of the eye, and the diplopia charting. These are two things which can be done in the bedside by the examining physician or the surgeon, which will give us further this thing. And the extent to which the two images are spread away from each other will tell us the severity of the problem. It quantifies the problem, and it will give us an idea as to how to manage the problem. Okay. Right. So the next question was, the marking of the foramen. I think Dr. Krishna himself did it. Could Dr. Krishna please tell us?
That's a blue one you marked was a superior orbital fissure.
Okay.
Then the second below that was foramen rotundum.
Okay. So you said this is the superior orbital fissure. Correct?
Yes, sir.
And
yes, sir.
this is the foramen rotundum.
I'm unable to see the image, sir.
Okay, you're not able to see the image? This is the image I had projected to you. Is it on your screen?
Yeah, okay, sir. Yes.
So this is the foramen rotundum.
No, sir. That one is lacerum, sir.
This is foramen lacerum. Okay.
Yes.
And this one?
That is ovale, sir.
That is foramen ovale. And this one?
Rotundum.
Rotundum. Okay. Dr. Harsh, if you could tell me what would be the structures which will be passing through these three foramen according to him. This is the foramen lacerum, this is ovale, and this is rotundum, right? If Dr. Harsh agrees with that, can you please tell me what is the main structure which passes through this?
Through the foramen lacerum, the part of the carotid artery will pass, which will be between the petrous and the cavernous part. Through the foramen oval, there will be the mandibular branch, and below it will be the otic ganglion, and through the foramen rotundum, the V2, that is the maxillary division of the trigeminal nerve.
Very good, excellent. So, Dr. Krishna, can you tell me these three structures, please?
Sir, that yellow structure Yellow arrows is petrosphenoidal ligament, sir. And below that is abducent nerve.
Okay.
And that blue mark seems to be, sir, fifth cranial nerve.
Excellent. Okay. That is exactly what I wanted. So that will be shown in the. Okay. So this is the foramen ovale through which the V3 segment goes in, and the V2 segment goes in through the foramen rotundum and the superior orbital fissure, as you had said. And these three structures, yellow indicates the Gruber's ligament, as it is called, which covers the Dorello's canal. The red arrow shows the abducens nerve leading to the Dorello's canal, and the blue arrow points to the trigeminal nerve. Good. So I think Krishna has completed his 3 questions.
Yes, sir.
Yes, thank you. So now this is for Harsh. I think this slide got switched. Okay. Okay. So I had asked
Debnath, me.
Dr. Debnath. Yeah, Dr. Debnath. The course of the abducen nerve and what are the parts?
Sir, first part is the brainstem part. Second is the cisternal part. Third is the Dorello's canal part. It is petrous apex part. Then the cavernous part. Then the superior orbital fissure. Then the orbital part.
Excellent. Okay, so the mainly it is divided into 5 parts. There's a nucleus and the central segment, which you call it as a brainstem part. Then there is a cisternal segment. Then there is a petrous segment. There is a cavernous segment, and then there is an orbital segment. Excellent. Good. So name the 3 syndromes, 2 medical and 1 surgical, associated with the abducens nerve.
Sir, 2 medical syndrome are the Fovile syndrome and the Tolosa-Hunt, and surgical will be a superior orbital and orbital apex.
Okay, so that's good. So I had just slightly taken a slightly different one, Millard-Gobler, which is what we read from undergraduate days. So it could be the Millard-Gobler syndrome, the Foville syndrome, as you mentioned, and the petrous apex syndrome, which is of more surgical importance, as well as Tolosa-Hunt syndrome, which is of more surgical importance. But Tolosa-Hunt may present with other things other than just 6th nerve. So it may be easier to come to a conclusion, but just pure 6th nerve, you have only in petrous apex syndrome. The commonest which we encounter would be the petrous apex meningiomas, right?
Yes, yes, sir.
Okay. So the next question was, how are we going to manage this patient's diplopia? How are we going to?
Sir, if there is a primary pathology, first I will manage the primary pathology, and otherwise we can do the medial rectus lengthening.
Okay, so you want to do a surgical procedure. Okay, let us say this patient has got a benign intracranial hypertension. It's a young lady, and her only problem is diplopia, and her headache is getting well managed with, say, acetazolamide. So she doesn't want any surgical procedure. How do you manage the diplopia alone? We cannot suggest her any surgery. What would you do? Anything medically which you can tell, which is easier, she can do it by herself, or with very simple advice you could correct it. Dr. Harsh or the Dr. Krishna?
Physiotherapy of eyeballs.
Okay, so the physiotherapist is going to ask you which hand to move. So what exactly will you tell the physiotherapist?
Sir, I will ask to tie a rope from the ceiling and a heavy object like ball or something, and tie to that thing, and we'll ask to move that slowly and keeping her head his or her head steady, and we'll ask to follow
So
that
it
ball.
is a good suggestion. Simplest thing would be to ask her to hold a pen in her own hand and move the pen from side to side and follow the object. But that will not help in improving the diplopia. We'll need to move the eye, which is not moving. So we need something called as a binasal occlusion spectacle. Okay, this is very simple. Just get a simple spectacle without any power if she does not have any refractory error. Patch the 2 medial segments of it, and then you can ask her to use So it's called the binasal occlusion. Okay, this is something which can be easily done and which this lady will be able to do. Any other ideas? The other two? Any other ideas? Tell me one more. I'm sure you should say this. Okay, if you don't know, it's called the Fresnel prism. So its purpose is to treat the diplopia, to compensate a fixed degree of alignment and to alleviate the compensatory head turn. If you do this, the patient will not end up tilting the head. Okay, so it is a slim, flexible plastic prism which is attached to the patient's glasses or a plano glasses. It's very simple. So these are the two things which you should mention. Okay, surgical procedures, yes. Surgical candidates you should mention, but first always try to mention non-surgical thing. Okay. Now, may I ask the next candidate? The next is going to be Dr. Amit from Hyderabad.
Yes, sir.
Okay. So this is case 2. We need to move on a little. Okay. The first 3 questions will go to you. This is about a 42-year-old man. He's a smoker. He's a laborer in construction industry. Carries heavy objects on hand. He complains of difficulty in walking and clumsiness in using fingers of 6 months duration and hyperesthesia, burning sensation of paresthesia in all 4 limbs of 4 months duration, has to strain while passing urine and also has constipation for 2 months. Not a diabetic, not a hypertensive. Okay, you memorized this?
Yes, sir.
Okay, now I want you to observe these 2 clinical tests which is being performed. Okay, I want you to name the reflexes and write down the root value for these 2 reflexes. You have 1 minute. Okay.
Yes, sir.
Right. So there you go. Please. Your time.
Ready, sir.
Okay, good. Right. So let's move to the next set of. This is another reflex which is being tested. I want you to name and write down the root value for this reflex. The time starts now. We will move on.
Over.
Okay, excellent. So I have, this is the last set of for you, Dr. Amit. Again, watch these 2 reflexes and let me know the root value of one of them. The other one does not have a root value. Okay. So name the reflex and please let me know the root value.
Over, sir.
Excellent. Okay. So Dr. Amit, you've got your 3 questions.
Yes, sir.
Next, I'll move on to Dr. Harsh for the next one. Okay. Dr. Harsh, you're on there. If Harsh is not there,
Yes, sir.
Yeah,
yes,
Harsh,
sir. I'm there.
Please tell me the clinical diagnosis from the above signs. Please write it down. We'll come back to it. Okay. Clinical diagnosis from the above signs with the history and the signs. What is your clinical diagnosis? Please write it down. Your time starts now. If you're ready, you tell me. I'll move on.
Okay, sir.
Okay. So as you know, this is a spine case. So you will need to mention the reflex level. You'll have to, sensory examination has not been given, but
Yes, sir.
from the examination, you know roughly the motor level also. So you can leave the sensory level out. You can just give me the reflex level alone. That is also fine with me. Okay. Right. So this next question for you is, name 2 grading scales which are associated with this disease condition, which you know of. Name 2 grading scale for this disease condition and please write down the 2 names and then let me know. Your time starts now. If you're ready, you let me know.
Done, sir.
Done. Excellent. Okay. So this is the last question for you, Dr. Harsh. Mention 1 other investigation before you decide on surgery for this patient. Okay. Mention 1 other investigation before deciding on surgery, and what surgery is best suited for this patient will be decided by that investigation. Do you understand? Mention one other investigation before deciding on surgery for this patient. And this investigation will tell you what surgery is best suited for this patient. Okay, you have your time start now and you have 1 minute.
Done, sir.
Thank you. So Dr. Harsh is completed. We'll go back to Dr. Krishna. Okay.
Amit sir.
Oh, okay. Amit already had 3. Okay. Amit can start. We'll give 1 question each. I think we'll have 4 more questions left. So Dr. Amit, please describe the MRI and X-ray. I want 2 points for MRI and 2 points for X-ray. Okay. Are you able to see?
Yes.
Yeah. So I want describe the MRI and the X-ray. I want 2 points for each. Your time has started. Okay. So let us say that this is the representative MRI and X-ray of the patient whom we have been discussing till now. Okay.
Yes, sir.
Right. If you're ready, you let me know and we'll move on. If I'm too fast, please tell me. I will slow down. Sorry, guys. You ready?
Ready, sir.
Okay. So the next question is to Dr. Debnath.
Yes, sir.
Name the 2 instruments which have been shown there. Okay. Name the instruments on the left and the right. Okay. Your time starts now.
Yes, sir.
Okay, good. So the last question, this goes to the, no, there are 2 more questions. This goes to Harsh. Is it okay?
Yes, sir.
Yeah, name 3 common complications of anterior cervical discectomy and fusion. Name 3 common complications of anterior cervical discectomy and fusion.
Okay, sir. Done.
Done. Okay. The last question to Amit.
Yes, sir.
Okay. Name 1 outcome scale for this patient, this disease. Okay. You have 1 minute and 1 mark for that. Name 1 outcome scale for treating, for when you treat these patients. Okay.
Okay, sir.
Done. So the last question, any one of you, what is disability index in cervical myelopathy? What is disability index in cervical myelopathy? Please write a little detail, take some time, take a minute, minute and a half. Tell me what is the disability index in cervical myelopathy? I think I'll be running short of time, so we really need to move on. So let's start with the first question. It was to Krishna, right?
Amit, sir.
Amit, sorry. So the values are already there on this one. So the exaggerated biceps reflex was the first one,
Yes,
right?
sir. C5,
Okay. And what is the value which he had written?
C5, C6, sir.
C5, 6. Okay. And the knee jerk?
L3, L4, sir.
Okay. Right. So it's already there. I'm sorry. So the Hoffman's reflex doesn't have a root value. Okay.
Yes, sir.
Right. The next question was to?
Me only, sir.
To you only. Okay. The clinical diagnosis from above sign?
No, no, sir. Not from me.
Sorry?
This is from Harsh, sir, I think.
Yeah, Harsh.
The clinical diagnosis from the above signs is cervical myelopathy.
Cervical myelopathy. Good. Okay. Possibly because of the inverted supinous.
Possibly above C5, so C4, C5.
Okay, good. The next question was also for you.
Yes, sir.
Name 2 grading scale for this disease.
So Nuric grading and modified Japanese orthopedic association.
Good. So modified Japanese orthopedic association scale and the Nuric grading. Okay. If you could quickly tell me the Nuric grading, then we'll move on.
The Nuric grading, C0 is sign of root compression without spinal cord. For grade 1 is sign of spinal cord but no difficulty in walking. 2 is difficulty in walking but patient can work. The next grade is that patient cannot work but able to walk without assistance. Then patient requires assistance to walk. Next is patient is chair bound or bedridden.
Okay, good. So the next question was to Krishna?
Me only, sir.
To you only. Okay. What is the one investigation which you would do, which would tell you what is the surgical approach which you will be taking?
Sir, the investigation will be MRI.
You would like to do an MRI. There is already an MRI there and an X-ray there.
Sir, at that time it was not there. So other than MRI, sir?
There was an MRI and there was a X-ray there. Okay. I will show you again. So there was an MRI. Okay. There is an MRI and there is an X-ray.
Yes, sir.
What one other investigation would you like to do for this patient before you decide?
Sir, nerve conduction study.
You want to do a nerve conduction study, and how would that help you in deciding on what approach you would want to take for the patient? I don't think it's going to help, isn't it?
No, sir.
Right. Anybody else? Any other answers? Anybody else?
Dynamic X-ray.
Dynamic X-ray.
You want to do a dynamic X-ray to see what?
Instability, sir.
Why? Why do you want to connect stability? From the MRI, what did you see?
MRI, sir, it is showing the degenerative changes with osteophytes and with cord compression and canal narrowing, sir. Okay,
that's very, very good description. But that's how a radiologist will describe. What is it that the surgeon should see? What you saw was at C4-5 and C5-6 level. Something you saw at C3-4.
Subluxation.
Above and below there will be spaces, maybe.
Yes, so there is a degenerative possible subluxation which is happening, or anterolisthesis is happening at C3 over C5, C4, C3 over C4. So you would like to do a dynamic X-ray, and that would tell us what is the best possible surgical treatment for this patient. So what do you think would be the best possible surgical treatment for this patient?
ACDF.
ACDF alone would be enough. At what level would you do?
C4-5 single level.
Single level, you would like to do an ACDF. Okay. Anybody else would like to counter him, and you would not do only an ACDF for this patient?
Sir, patient have subluxation also associated, so we have to fix it, sir.
Correct. So there is a subluxation at the higher level. If we do a C4-5 discectomy and fusion alone, you will have a exacerbated or more accelerated adjacent level degeneration. Therefore, we will have to fuse him from C3, 4, and 5. Okay.
Yes.
So the ideal treatment for him would be an ACDF with stabilization. Okay. Right. describe the MRI and the X-ray, which you guys have done already. So the next one was who was that to?
So, I mean,
The instruments.
So one is Cloard self-retaining, another one is Caspar self-retaining detector.
Okay, so we all think that it is a Cloard who introduced it and Caspar who introduced it. Slight difference. The retractor was actually introduced by Professor John A. McCullough, and it was modified later on by Cloard. And the pin distractor for the vertebral body was indeed introduced by Dr. Caspar. That's correct. Okay. So who had the next question? The complications? Harsh?
Yes, sir. I had that question, sir.
Yeah. So what is the complication? 3 common complications.
Soft tissue like esophageal or tracheal injury, then nerve injuries like recurrent laryngeal nerve injury or postoperative hematoma.
Okay, so all 3 are correct complications which can happen, but in not in very good safe hands or very good hands. That will all those 3 complications should happen. So even with good hands or trained hands, the more common complication would be dysphagia. Palsy and graft extrusion. Okay, right? So if they ask you for common complication, it should be for commonest possible. So dysphagia is more common than esophageal injury. C5 palsy is definitely more common than tracheal injury, and graft extrusion happens much more commonly than in hematoma. Okay, right. So the last question was name one. I mean, 2 last questions. Name one outcome scale. Disease. Who was that to? Krishna?
No, sir, I don't know.
Okay, you didn't know what. Anybody else who could help? Other 3?
So Frankel scoring, will it be helpful?
Okay, so it's called Odum's outcome scale. Okay, so all preoperative symptoms relieved is excellent. Good is minimal persistence of preoperative symptoms. Abnormal findings unchanged or improved. Fair is definite relief of some preoperative symptoms. Other symptoms unchanged or slightly improved. Poor symptoms and signs unchanged or exacerbated. Now, this is an Odum's outcome scale, can be used for any disease as such. Okay. And the last question was, what is the disability index? Whom was that for? Anybody had an answer?
No, sir.
Okay. So the myelopathy disability index, which is ranked according to each is given a value, rising from a chair, eating by himself, walking with help or without help, hygiene, whether how good his grip was, and the activities, and the score is out of 30. Okay. 0 is without any difficulties, 1 is with some difficulty, 2 is with more difficulty, and 3 is unable to do it. Okay.
Okay.
Right. Okay, Dr. Manas, anything else you would like to add on to?
No. Thank you. Now we have to go to the next because
it's quite late. Thank you
for conducting it very well. And request Dr. Chandan from Bombay Hospital to start his sets of question. Dr. Chandan, can you please share your screen?
See my screen? Can you see my screen?
Yes.
Yeah, yes.
Okay. Okay. So thank you, Professor Manas and Professor Muthu Kumar and Professor Suresh Nair, sir, for this opportunity. And all the best to the 4 candidates. So straight away start the first question. So we have a history, a 38-year-old road traffic accident, tailor by profession. 2-wheeler had a skid and fall 4 days back and has been unable to move his left upper limb since then. He complains of diffuse upper limb pain with a VAS score of 9 out of 10 since 1 day. On examination, he has abrasions over the face, chest, and shoulder, fracture of left humerus, which is in cast, fracture of the left clavicle, which is in sling, multiple abrasions and sutured lacerated wounds over the forearm, no wound soakage. Patient is not cooperative for a detailed examination due to the pain. but grossly the left upper limb is 0/5, both proximally and distally. So what do you want to do at this stage for this patient? So time starts now. So I think I'll start with Harsh. Once you are ready, you let me know.
Okay, sir.
Okay. So what do you want to do at this stage?
Sir, should I answer now?
Yes.
Okay, sir. From the history, this looks like brachial plexus injury, and the patient is having probably flail limb. So at this stage, I would like to go for an investigation, which way can confirm my diagnosis, like MRI.
Okay. So anyone else wants to take this? Dr. Amit?
Sir, first we have to stabilize the patient and give pain, because he is not cooperating with pain, so we can't do any MRI or anything. So if
so what do you think is the reason of the pain?
Reason is the pain is brachial plexus injury.
Okay, so Dr. Debnath, you want to
answer?
You want to add anything, or you agree?
Sir, pain may be due to the fracture also. So we need to stabilize the fracture either by the slab or by the orthopedic team, and then pain management. Then we will plan our management accordingly, like MRI or EMG and CV. Then accordingly we will do. But first stabilization of the fracture.
So fracture is already stabilized in a cast. Clavicle fracture is already in a sling. So who's the last one? Dr. Krishna, you want to add or say anything else at this point of time? What you want to do?
Root compression due to some cause, sir.
So actually, all of you have got the answer incorrect. So the reason, what you suspect in these patients is associated vascular injuries, especially clavicle fractures. You can have axillary artery injury. With fracture of the humerus, you can have radial artery injury, or you can have a median nerve injury. Also, I told you that the forearm had multiple soft tissue lacerations. So very high suspicion of vascular injuries since in this patients. So you have to open the dressing, make sure the patient is having properly palpable pulses. There is no evidence of compartment syndrome, and you would order a vascular imaging for this patient. If I go back to the slide again, so fall was 4 days back, but the pain has started since 1 day. Okay, so a root injury pain, if at all it has to happen, it will start early. Doesn't happen with a lag of 3 or 4 days. Okay, so that is one. And because the patient is in cast and a lot of soft tissue injuries, you have to suspect vascular injury or a compartment syndrome. Okay, so now the peripheral pulses were weak and there was poor capillary filling time. Dressing was removed and there was dramatic improvement in the pain. So left upper limb was still 0/5. There's complete sensory loss in C5 to T1. So Dr. Harsh, what investigation you want to order now? And the second question is, when do you want to see the patient? Any investigation do you want to do at follow-up? And what is the rationale for doing the investigation at follow-up if you want to do something later? So take some time. Once you're ready, Dr. Harsh, you can tell me.
Sir, as this clinical picture is of compartment syndrome and vascular injury, and after dressing was removed, there was a dramatic improvement. So we can suspect if there was there is complete sensory loss in C5 to T1. So we can suspect if there is any neuropraxia injury to the nerves. They cannot be this severe, but it can be neuropraxia. So to what investigation I can under nerve conduction study? And when do you want to see the patient? Neuropraxia generally recovers within a few days. So I would like to see the patient again after 4 to 5 days. And again, then repeat the same investigation see if there is any recovery of the nerves.
Okay, so Dr. Amit, do you agree, disagree? You want to add something else?
Nerve conduction study and EMGs are better. They will give result after 3 weeks. Then
Correct. Correct. So the correct answer is what you said is that at this point of time, actually, okay. So you are not going to do any tests at this point of time. That is 4 days after the injury. You're not going to do any tests. The Valerian degeneration takes about 3 weeks to complete. So you have to do EMG and nerve conduction test only after 3 weeks. The earliest you can do EMG and nerve conduction study is at 3 weeks. MRI, it takes about a month for the pseudomeningoceles to develop. So for the preganglionic injuries, to find out whether there's preganglionic or postganglionic injury, usually the MRI is done at first month. So this is one of the rare cases where you don't investigate the patient immediately. You actually wait. You have to rely on your clinical examination, and then you have to wait, give it some time, and then do the tests. Okay. The other thing is what you were saying, the neuropraxia can be 0/5, but neuropraxia doesn't recover in 3 or 4 days, Dr. Harsh. Okay.
Okay.
So let's go to the next question. Okay. So Dr. Debnath, do you want to answer what is the Naraka's rule of BPI, brachial plexus injury?
No, sir.
Dr. Krishna, you want to answer this? Take this question.
No, sir, I don't know. Sorry.
Okay. Anyone else? Okay. So actually, if you know this rule, you will know the entire epidemiology of the brachial plexus injury. So this is the rule of 770s. So 70% of brachial plexus injuries are secondary to motor vehicle accidents. 70% of the motor vehicle accidents are due to motorcycles or bicycles. 70% will have multiple injuries. 70% of these multiple injuries will have a supraclavicular lesion. 70% of the supraclavicular lesions will have at least one root avulsion, and 70% of the involved root will be either be C7, 8, or T1. And 70% of the avulsed root would have some amount of chronic pain. Okay. So this is an important rule. So if you know this one single, you can write about the epidemiology and of the brachial plexus injury. So now the patient has come after 3 months. He's saying that he has recovered some function in his hand. So when I examine him, he has a normal diaphragm. Trapezius is 5/5. Levator scapulae, rhomboid, supraspinatus, infraspinatus, deltoid, biceps, supinator, brachioradialis, serratus anterior, latissimus dorsi, subscapularis, teres major is 0. Pectoralis, abductor pollicis longus, palmar and dorsal interossei, abductor pollicis brevis, opponens pollicis, adductor pollicis, lumbricals are 4-5. Triceps, extensor carpi radialis longus, brevis, extensor carpi ulnaris, extensor carpi radialis, EDC, pronator quadratus and pronator teres are 2/5. Flexor digitorum profundus and flexor digitorum superficialis in all the fingers are 3/5. So now I want you to localize this lesion and tell me the root values which are affected. Okay, so think over it. This is almost like a mathematical problem. You know the muscles, you know the root values, you will be able to find out where the lesion is. So you'll have to tell me whether it's preganglionic or postganglionic, then whether it's affecting the root, the trunk, the division, or the cord, or the nerve. So take your time, think over it, see the muscles, try to remember the root values, and then make a comment. So once you're ready, you let me know. Okay, Amit.
Sir, because of serratus anterior and rhomboides, it's looking like root avulsion. C5, okay, C6, C7, and then upper trunk also, sir, injury.
Okay. So upper trunk is included, no? In
yes, sir. Root,
6 and 7.
Yes, sir.
Yeah. Anything else, Dr. Krishna? You want to add something? Is Dr. Amit's answer complete or incomplete?
Yes, sir. Serratus anterior is also involved. So, sir, C5, C6, the root must be damaged, sir.
Okay, Dr. Harsh, anything else?
And maybe avulsion, sir, because power is 0.
Okay, Dr. Harsh. Anything else? Dr. Debnath, you want to add anything else? Okay, so Dr. Amit, you were partially correct. This is indeed a. Is the slide moving?
No, not moving.
Okay, so it is indeed a preganglionic injury with neuropraxic injury of C8 and T1. So why you? So as you rightly said, the three muscles, the rhomboids, levator scapularis, and serratus anterior are 0/5. Hence, it is a preganglionic injury. As far as levels are concerned, again, four muscles help us: serratus anterior, latissimus dorsi, subscapularis, and teres major, all of which are 0/5. So triceps, all of you like to think that triceps is C7, so triceps should be 0, but no, triceps has a C6 to T1 innervation, so it is only 2/5. The lower roots are intact. Since there's good recovery in this hand intrinsics, so most probably it's just a neuropraxic injury of C8 and T1, which is in the recovering phase. Okay, and it is a preganglionic injury of C5, C6, and C7. Okay.
Okay, sir.
Okay, so now what is the nerve supply and root value of the following muscles? Dr. Debnath, whenever you are ready, you let me know the answer. The four muscles are supinator, abductor digiti minimi, rhomboids, and flexor digitorum profundus of the middle finger. Dr. Debnath, you are ready?
Sound is not coming.
Dr. Debnath, you ready with your answer?
Is it audible, sir?
Yeah, now I can hear you.
The supinator, sir, your root value is C5, C6, and it is supplied by ulnar nerve, sir. Okay, I'm not sure, sir. I forgot, sir.
Radial nerve.
Oh. Yes, it is by radial nerve, but root value is correct. It's by C5, C6. What about abductor digiti minimi?
Abductor, your digiti minimi, it is by the median nerve, and root value is C8, T1.
No.
Ulnar nerve.
It is by ulnar nerve. Okay, Dr. Krishna, you want to take rhomboids? Root value and the nerve, name of the nerve.
Robert, the root value is C5, and nerve is suprascapularis.
No. Dr. Harsh, you want to take rhomboids?
Dorsal scapular nerve, sir.
Good.
And your root value is, sir, C6, sir.
No, wrong.
4, 5, sir. C4, C5.
C4, C5. Good. Dr. Amit, you want to take the answer for flexor digitorum profundus, middle finger?
Flexor digitorum profundus, middle finger is from the branch coming from median nerve, sir. And
Sure.
it is C7, sir.
No. So, so some answers you got correct, some answers you got wrong. So it is by C8. It is not by median nerve. It is basically by the anterior interosseous nerve branch of the median nerve. Okay. The dorsal scapular is extremely important because that will take for the rhomboids is extremely important, because it tells you whether it's preganglionic or postganglionic injury. Root value is C4, C5. Ulnar nerve, abductor digiti minimi, and the root value is T1. It is a key muscle for T1. Flexor digitorum profundus is a key muscle for C8, and for C6, that is supinator, is the key muscle. Okay, so that's the reason why these muscles have been picked out of all the muscles which could have been asked, because these are the key muscles, and these muscles you have to know the root value and the nerve supply. Okay.
Okay, sir.
Okay, so Dr. Harsh, identify the deformity and explain its features. Why the hand position is like this? Whenever you are ready, you let me know. Are you ready, Dr. Harsh?
Yes, sir.
Okay, tell me, what is the deformity and why is the hand position like this? What is
So
the name of
the deformity is known as policeman's step deformity, and it is due to the upper trunk injury, and it is due to weakness of shoulder abduction, elbow flexion, and supination.
Very good. But why the fingers are curled?
And loss of finger extension.
No, because fingers are curled because median and ulnar are intact, right? That's why the medial this thing is curled. So good. That's called as a either waiter's tip deformity or a policeman tip deformity. Those are the two names for this. One second. Right. Okay, the slides are not moving. In a second.
Should I share, sir?
Yes, Sriram, you can share it, please. Thanks. I don't know why suddenly it kind of freezing. Okay, I think now I got control. It's okay, Sriram.
Yeah.
Okay, so this is called a waiter's tip hand or a policeman's tip deformity. Correct. The lesion is at this is due to Erb's palsy. Classically, most commonly seen as part of OBPP, and due to excessive displacement on traction on the plexus when the baby is being delivered, and it has one of the best prognosis for brachial plexus injuries. And you rightly said axillary, suprascapular, and musculocutaneous function is hampered. That's why the hand falls like this. And supinator is weak because there's involvement of the C5-6 root. Okay, good. So, Dr. Krishna, can you tell me what are the features of Klumpke's palsy? And once you're ready with the answer, you let me know.
Sir, hello.
Yeah.
Sir, it is a lower trunk injury.
Okay.
Wrist and hand are mostly involved.
So what happens? Can you be more specific, Dr. Debnath?
Sir, it's a hyperextension at the MCP joint, it is metacarpophalangeal joint, hyperextension at the wrist, and flexion at the interphalangeal joint.
Okay, and what is it called? Deformity. What is it called?
Sir, yes, with claw hand, sir, claw hand deformity.
What happens to the wrist?
Pardon, sir?
What happens to the wrist? What is the
Sir,
position of the wrist?
it is, sir, hyperextended, sir.
Okay, why is it hyperextended?
Median now damage.
You're right. It is hyperextended. Why it's hyperextended? Okay. Anyone wants to take that? Why? No.
Median and ulnar now.
Radial nerve overcomes, sir, due to extensor digitorum.
Yeah. So because of excessive, because you should remember that anti-gravity muscles are always much stronger. So wrist extension and finger extension is an anti-gravity muscle function. So that's the reason why the hands are in hyperextension. Okay, exactly like you described. So this is a typical claw hand where there's hyperextension. This is different from the claw hand that you will experience in, say, a distal ulnar nerve injury or median nerve injury. Okay. So this is usually associated with a preganglionic injury, and they have very poor prognosis, and they are usually associated with Horner's. So that is the complete answer for Klumpke's palsy. In contrast to the Erb's palsy, which I told has a very good prognosis and usually is postganglionic in nature. Okay. Okay, so Dr. Amit, can you tell me the role of X-rays in brachial plexus injuries? Take your time, think over it, and let me know whenever you're ready.
Ready, sir.
Okay, go ahead.
Uh, if X-ray showing any transverse process fracture, then it is mostly going toward the preganglionic fracture, sir, and medial third of clavicle. But lateral third clavicle, if a fracture, then it's going toward post-ganglionic fracture.
So you want to see fracture of the spine and you want to see fracture in the clavicle. Anything else, Dr. Harsh? You want to add something?
Sir, diaphragmatic palsy, sir, it can be seen, sir, upward movement of the diaphragm on both side.
Very good, very good. So that is a critical thing that you see in the X-ray. We often ignore the X-rays, but X-rays, first you see the C-spine, if there is any fractures, then you see clavicle fractures and fracture of the first rib, extremely important for T1 root injuries. Okay, and you see whether there are any cervical ribs. So that will be, if there's a patient with cervical ribs, that will be almost be like a double crush. So one will be maybe proximally and one will be at the level of the cervical rib. Other rib fractures are important because if you want to do a nerve transfer, you have to take an intercostal nerve. But if the intercostal nerve is already damaged because of a neuroma or because of the nerve getting stuck in the callus of the rib, you can't use that level. You have to use some other level. So that is in terms of surgery. And diaphragmatic palsy is the most important thing. That's the reason why you have to do a inspiration X-ray. Okay, so Dr. Harsh, identify the sequence of the MRI and you have to tell me how this particular sequence is useful compared to the routine sequences of MRI. Your time starts now. So whenever you're ready, let me know.
This is MRI coronal, and the sequence is STIR sequence. It is the short tau inversion recovery. And this sequence is useful as compared to routine sequence because in this sequence, the fat suppression is done. So the structures that are surrounded by fat can be seen more clearly and any acute injury or acute edema can be seen in a more pronounced way.
Okay. So anyone else wants to add anything?
Any muscle involvement? Any some muscle involvement, so it can be like the scalenus muscle. If there is some edema or scar tissue formation, and it will be the image from the fat is suppressed because fat is also hyper intense. But if we suppress the fat in STAR, then if there is any hyper intense signal in the scalenus muscle, so it will indicate some idea about.
Okay, so good. So idea is correct, but partially correct. So this is actually STIR. This sequence is called as the MRN sequence, the MR neurography sequence, which is basically STIR with a variable flip angle evolutions. That is called as the space flips. Okay, so what you see is that you see the internal fascicular pattern of the nerve much better. And as you rightly said, you can identify the denervation edema. So you can localize which nerve is affected by seeing which muscle. So if you see the supraspinatus and infraspinatus, you know that suprascapular nerve is getting involved. If you see some denervation edema in the serratus anterior, then you know you're dealing most probably like with a preganglionic injury, even if you're not able to exactly localize a root tear or a pseudomeningocele. Okay, so and with improving, so with a higher grade of Tesla, like 3 Tesla or even 5 Tesla, 7 Tesla, which are coming up, you can probably, the future role is that you can substitute exploration and interrupt stimulation of a lesion in continuity, especially if it is in the plexus, and you can directly do the distal nerve transfer without exploring the plexus. So that is the main advantage. One is the emerging advantage. Other one thing you said correctly was to suppress the fat sequence. But this particular sequence is called as MRN. Okay, so this is how it looks. So this is the previous picture, and you see carefully, you see the hypodensities in the nerve fascicles compared on the red side. So those are the C8 and the T1 roots. So those you see that it has scarred. So it is most likely a post-ganglionic injury of the C8 and T1 roots. Okay. compared to the upper roots and the upper trunks, which look absolutely fine. So this one, I'm sure all of you know the presence of pseudomeningoceles, cord contusions, or avulsion of the root from the cord. Okay, this is a very standard question, and I want Dr. Debnath to answer once he's ready. Take some time. You have to enumerate all the differences between the pre and post ganglionic injuries.
Chandan, we are almost more than 30 minutes.
Okay. Okay. So I'll take this question and then I'll stop.
Okay.
Okay, you can start one by one. Dr. Amit, you want to start?
Sir,
sorry. Yeah.
Preganglionic is more associated with Horner syndrome.
Correct.
And bad prognosis, sir. Along with that, paravertebral muscle atrophy associated with preganglionic. And then Tinel sign is negative for preganglionic, sir. And when we do sensory nerve action potential SNAP and CMAP, both are positive for preganglionic.
So basically they are preserved.
Yes, sir.
Anything else? Dr. Krishna, you want to add anything else?
Sir, in preganglionic, motor and sensory root are can be different, sir. Injury can be isolated to motor or sensory. And the preganglionic cannot be repaired, and postganglionic can be repaired, sir, by surgically.
Okay, so so you have to go stepwise. You start with mechanism, then you examination, bringing up the scapula, levator scapulae palsy, rhomboids, Horner's palsy, diaphragmatic palsy we discussed a few minutes back, right? So that is important. Sensory loss above the clavicle usually means you are dealing with a preganglionic injury. Very, very typical sign. MRI features pseudomeningocele, root avulsion, empty nerve root. Electrophysiology, you rightly said, Dr. Amit, denervation potentials in paraspinal and preserved snaps. Histamine test is when you drop a ml of histamine, you should see the triple response, redness, wheal, and flare in preganglionic. Prognosis is poor. Okay, so I think I'll stop. Once we get time, we can probably cover the next question. Thank you.
Okay, thank you, Dr. Chandan. And if you have, means we could have more questions if we had time. Next time we'll get a chance. So I'll now request Dr. Vamsi from Nizams Hospital to conduct his sets of questions.
Thank you, Dr. Manas, Dr. Nair, and Dr. Muthukumar, and Dr. Chanda for giving the opportunity. So I'll be presenting two cases like this, two short cases. So the first case is a 5-year boy with GTCS and vomiting. On examination, he is conscious.
Slideshow, please.
Okay, I'm sorry. Yeah. Yeah, so 5-year boy presented with GTCS and vomiting for the past 7 days. He had an examination, he had visual acuity of 3 conscious, visual acuity of 3 feet, and bitemporal hemianopia. So what is the anatomical localization, Dr. Amit?
Anatomical localization is cellular supracellular lesion, sir.
Okay. So what is the differential diagnosis, Dr. Dwaipayan?
Sir, craniopharyngioma, then astrocytoma, then though the age is less, but any pleural adenoma, then arachnoid cyst, and then cavernoma, then germinoma.
In order of, okay, so it's cellular supracellular lesion is right, and craniopharyngioma, and one is the other one. Need to consider the glioma is one possibility, definitely, and germinoma. Pituitary macroadenoma is a very low down, looking at the age. and Lathkesh clefsis as well. I mean, lower down. What is chiasm within chiasm, Dr. Harsha, and what is its significance?
Chiasm within chiasm is generally the splitting of the macular fibers that happen within the chiasm.
And what is its significance?
Significance, sir, I'm not sure.
Okay. Dr. Krishna, can you answer that? Anyone else?
No, sir.
Okay. So the inferior retinal fibers, they decussate down, and the superior retinal fibers decussate on the top. And you have the macular fibers in the center. So if you have a pituitary adenoma that's growing from down, so what you look at is the first compression is on the inferior retinal fibers. So you have the superior temporal field defects. And if a craniopharyngioma growing from the top or some other glioma and compressing the fibers, the first fibers to be affected are the superior retinal fibers. So you have an inferior field defect. So that's in a way helps in localizing from where the tumor started. I mean, if someone kind of has can get a better history on that. Okay. So this is the scan of the patient, CT. Can I go to the next one? That's the MRI. So what is the most probable radiological diagnosis? I'm not even asking for differentials much.
Craniopharyngioma.
Most probably it's looking like a craniopharyngioma.
Okay. Yeah, that's right. Dr. Dwaipayan,
Yes, sir.
What are various sites of origin in the hypothalamo-pituitary craniopharyngiomas?
Sir, it can be from the infundibulum, it can be from the floor of the third ventricle, it can be a cellar, and it can be also a paracellar also, sir.
Paracellar is not the origin line. So in the hypothalamo-pituitary axis, what are the various sites of origin?
The infundibulum.
Correct.
Then it can be from the floor of the third ventricle.
Mm-hmm.
It can be from the cellar, intracellular origin.
Okay, 3. It can be completely inside the third ventricle from the ependymum.
Yes, sir.
Okay. Yes. So like this, I mean, you have from the dorsal the dorsal surface of the pituitary, pars tuberalis, pituitary stem. From there it can come, or it can come from the median eminence or tuber cynarium. But it can come from beneath the ependymal layer of the within the third ventricle. So you have seen the scan. So in this particular scan, when you are looking at a surgical aspect, what is the topographical extent of the tumor? If you want me, I can show you the scan again. Yeah. Dr. Harsh, maybe the next one, I'm sorry. Dr. Harsh?
Yes, sir.
Can you answer this question? What are the topographical extents in terms of planning your surgery and other aspects, extent of surgical dissection and other things?
Sir, the topographical extent is the lesion is occupying the whole of the sella, and it is displacing the entire anterior part of the third ventricle, and it is going up to corpus callosum, and interiorly also it is projecting into the frontal lobe, and on the axial cuts.
Okay. So that's the extent that you would like to note in this.
Sorry, sir.
So is it compressing the third? Is it lifting up the third ventricle, or it's inside the third ventricle?
It looks like it is inside the third ventricle.
Okay. So what are the different based on the origin? I mean, what is the different text? Okay, I'm sorry. I'll come back. So the thing, yeah, I mean, as you said, like it has in the sella, it's there even into the third ventricle, it has gone subfrontal. So it's in a way a multi-compartmental one.
Yes, sir.
So it fits into kind of something which originated and has almost extended everywhere. Like, I mean, it's a kind of a giant one.
Yes, sir.
So as I said, I mean, this is the other thing that that's important. I'll come back, go to the next question and ask you. Like, so what is the possible degree of hypothalamic adherence and its displacement in this? And why it is important in a 5-year kid? You can go to Krishna, Dr. Krishna.
Sir, hypothalamus makes the floor and lateral wall of third ventricle, and as the anterior part of third ventricle cannot be well appreciated, sir, it have been possibly adherent to that thing, sir. And it is important because of
yeah, please.
Sorry, sir.
Please go ahead. Yeah.
Yes, because it is important because the damage to hypothalamus can lead to somnolence and cognitive deficits for a long time, sir, in pediatric patients.
Which way you are expecting?
The addition is
which way the hypothalamus is displaced in this? Is it on the top of the tumor, on the sides, or where is it exactly?
Sir, below and lateral, sir.
So this is the displacement of the hypothalamus based on various how the tumor has. If it is in the sella, like it's on the top, and it's the top image is the one which is completely inside the third ventricle. So in this, the hypothalamus is intact. So below is the one which is there in the third ventricle, B2, and it has gone down and up till the extended up till the infundibulum. So it has displaced laterally, and so the third one is the one which is extending almost all the compartments. So, and the fourth one is the one where it has lifted the third ventricle but has not invaded the third ventricle. Sorry, the tumor has lifted the hypothalamus because it hasn't entered the third ventricle. So the hypothalamus is still intact. So there are, the severity of adhesion to the hypothalamus can be kind of assessed based looking at the tumor extension and as well as the shape of the tumor. If you see the last two images like D2 and E2, you see that this has invaded, it's a kind the shape like bowel-like or ring-like. They are the ones, I mean, extending into the third ventricle are the one which have a severe, very firm adhesions to the hypothalamus. So what is the endoscopic classification of craniopharyngioma? I mean, by Some et al. I mean, based on that, there are several modifications for endoscopy. And what is the basis of these classifications? Why it is required? Because there are a lot of other classifications that are available. Dr. Amit.
Don't know, sir, endoscopy classification.
Okay. And Dr. Dwaipayan, anyone can answer?
Sorry, sir.
Anyone else can answer this? Okay.
No, sir.
When you are going from endoscopy, like the first encountering is the pituitary gland, and then the stalk, and then you are going up. So that's why in the endoscopic classification is based on what is the position of the infundibular stalk. And the fourth one, infundibular, transinfundibular, which has completely occupied the infundibulum, and the retroinfundibular, which is behind the infundibulum, and into the interpedunculair system. So, and the fourth one is an intraventricular tumor. So which of the intraventricular, completely third ventricular tumor, you don't want to operate by endoscopy because you are destroying a normal intact hypothalamus. So what is the surgical approach and why? Dr. Dwaipayan. Dr. Dwaipayan.
Hello.
What is the surgical approach for this patient?
Sir, a subfrontal approach, sir. And we will go through the right subfrontal approach, sir, because it is the non-dominant lobe. And
and what is the other factor that you look at? I mean, when you are planning such a right side or left side in a particular?
The vessels, the ACAs.
ACAs. So in this, like this patient has typically two large cysts which have extended under the frontal lobe.
Yes, sir.
Or even suppose if it is a solid. So what are the factors that you otherwise look at?
Calcification, sir, degree of calcification.
Because if you see,
bony erosion.
It's quite, see when you are going, you want to see the opposite side. When you are going from the right side, the left side cyst which has extended up is better visible. See this, the left side cyst has, if you see in the sagittal sections, it has extended quite high into the subfrontal. So you want to do the dissection, you go from the contralateral side, it's better visible than the ipsilateral side.
Okay.
So what is the surgical, okay, that's subfrontal as I said. What are the tumor factors not favorable for an endoscopic approach? Dr. Harsh?
The tumor factors which will be not be favorable for endoscopic approach are extensive supracellular extension or paracellular extension into any of the lobes, or entry of the tumor into cavernous sinus.
That's it. Any more?
Sir, calcification, if the calcification is more, then it will be difficult to remove by endoscopic approach.
Yeah. And what else?
Adhesion to the surrounding structure, sir.
Like generally so vascular, craniopharyngium is not so much vascular. So
adhesion to the surrounding structure, sir.
I already described one. Like,
obviously, the
the one which is completely inside the third ventricle. I'm sorry. Okay. So the multi-compartmental one, as you guys said, extensive thick calcifications. Like, I mean, this patient has a very thin calcifications. I mean, that not, but if it is confined to the cella and just the supracellular region, it may still not preclude an approach. So one is tumor extending lateral to the carotids. I mean, that's one of the, yes, into the cavernous. And tumor confined in the third ventricle. So you don't want to damage the hypothalamus by going from below. So as I have shown in the classification, that's one of the factors. So what are the hormonal supplementation required following craniopharyngioma surgery? When you do a gross total to near total excision? And what is the immediate hormonal requirement and what is the long-term hormonal requirement in the follow-up? Dr. Harsh?
So the immediate hormonal requirement will be this corticosteroids.
Mm-hmm.
And so after gross total excision, because of the compression by the tumor, the pituitary gland will not be functioning. So initially all the hormones will have to be replaced. And later on that after a period
what are all the hormones that you're talking about in the immediate post-operative period? How do you assess, like, I mean, whether something is required or not?
So clinically?
Clinically, or you want to do a test? I mean, that's up to you. The patient is in front of you after surgery.
Post-operatively,
yeah. So do you determine cortisol thyroxine? I mean, you'll give upfront, or if you supplement immediately and then want to do something? And anything else when you're particularly talking about a gross total excision or a near total excision?
Mindrin, sir?
Yeah, that's a question. So most common is when you are going for a gross total excision, most of the close to 70 to 80% will require vasopressin supplementation. I mean, Mindrin buffer because of the DI. And cortisol and thyroxine, the steroids generally you tend to give it, but thyroxine supplementation, everything can be done based on your post-operative hormone profile assessment. And what is the long-term? What do you give? What are the hormone supplementation? Because he's a 5-year kid, and what are the hormones that you want to supplement at later, in addition to the ones that you are looking at based on your
growth hormones are more important.
And what else?
Gonadotropes, sir.
Okay, wonderful. So GH and GnRH is very much required for to maintain his normal puberty, adolescent puberty, and as the growth hormones supplementation is required, you need to refer the patient to the endocrinologist. So what is Diane-Kefalik syndrome? This goes to Dwaipayan.
Sir, it is basically the loss of subcutaneous fat with normal linear growth, and it is basically due to compression over the diencephalon caused by the like some space occupying lesion like hypothalamic or chiasmatic astrocytoma or any other lesion in this area, sir. Basically, it's the loss of the subcutaneous tissue with the maintenance of normal linear growth.
What are the other things that you look at in these patients?
Pardon, sir?
What are the other features that these patients have?
They will having the visual loss, sir, the impairment of the vision, and
so you look at the patient. I mean, what is the overall? So why is this happening?
Patient's failure to thrive, sir, hectic patient, visual loss.
Is it only cachexia that the patient has always? Hectic or obese, like anything is possible. Okay, so this involves because of damage to what? Okay, I mean, the answer is there in front of you. So the damage to the anterior hypothalamus, and patient can have obesity, patient can have emaciation, and they could be, as you said, like a lot of subcutaneous adipose tissue, and they can be locomotor hyperactivity, euphoria, and alertness. And there are many neoplasms, like any kind of supracellular lesion can cause it. So what are the other adjuvant therapies? Sorry, I have the answer already.
For residues or later, we can do the scan after 3 months, and if residue is there, then stereotactic radiosurgery we can advise.
So in this particular patient, 5-year kid,
sir, it is the main.
And which parts you would like to leave in this, and what would you like to do?
The main component is cystic, sir, cystic lesions. So then we can do intracavitary bleomycin injection, or we can do intracavitary radiation also, and we can put a Omae reservoir and multiple aspiration.
So these intracavitary, see in this particular patient, because he's a 5-year kid, if you have dense adhesion to the hypothalamus, you would like to leave that portion, because you want to maintain a normal growth and maintain the quality of life of the kid, and always can. This kid, you won't like to irradiate. Okay, so you will follow it up, and it's very much possible in this patient. You don't have to leave any cyst, like it's possible to excise it. So if you have left the cyst by any means, like, okay, the options of the bleomycin. Okay, so these are the possibilities that the options you have, but you won't like to, in this patient, most probably you won't require it. So we have, so what is the diagnostic criteria of DI?
Diagnostic criteria for DI is, if urine output immediately post-op more than 250 ml for consecutive more than 2 hours, or more than 1 liter for 4 hours,
No, in a kid, like 5-year kid, like what is maybe 20 kgs. So what is the urine output you are looking at?
More than about 3 times of body weight, sir. So 20 means 30, 60, more than 60 ml per hour.
So what are the things you want to measure?
And hypernatremia, urine output and hypernatremia.
Urine and urine and
serum osmolality and specific gravity of urine, sir.
Wonderful. And this is 3 cc per kg per hour. That's what you need. In the kids, like you need to be particular about per hour. You need to know the amount of the urine output cutoff that you want to look at.
Yes, sir.
So since I'm running, so what is the treatment of DI in a conscious patient with mild DI and severe DI? In a conscious patient, you have a mild DI. So what would you like to do?
If patient is conscious, he can drink.
Severe DI.
Okay, sir. If patient is conscious, sir, so if he feels thirsty, he can drink whatever want water, sir. But patient is not conscious, then we have to give supplements.
Sir, in mild DI in a conscious patient, you will give. You would like the patient to drink. And if severe, I mean, you still have to, because he cannot keep kind of pouring out a liter of urine in an hour and keep on going to the washroom to pass the urine. So you still have to give a nasal spray. And what would you do in a comatose patient? DI.
For hypernatremia, plain water, sir, and then desmopressin we can give.
Desmopressin, how would you like to give desmopressin? Preferable
puff, sir, this intranasal puff.
Yes, tube all the way. So, okay. So, preferable is
sublingual.
Yeah. It can give those fluids. So, and coming to the next case, like it's a 4 baby, full-term normal vaginal delivery, had an head size, increasing head size. So the patient came with vomiting and decreased breastfeeding for the past 10 days.
This one.
I'm sorry. Okay, we are running out of time already. Beyond. Yeah. So head circumference is 50. I'll just ask 2 questions on this. The most okay. Name some clinical signs in infantile hydrocephalus.
Clinical sign is upward gaze palsy, means sunset syndrome in the eye, sir, and there is dilatation of the scalp vein, and the failure to thrive, means patient baby not eating properly and irritable.
No, that's not a sign. Like, so you want to look at Messi 1 sign, sunset sign, and Walport sign. Walport sign is about the INN is low when you have aqueductal stenosis, and in case of dandy walkers, the INN is high. So that's the one. So what else would you like to examine in this patient?
Lower back examination for any meningocele or meningomyelocele.
Wonderful. Okay. So what is the normal incremental growth of head circumference?
Sir, at birth 33 to 35 centimeter, and after that next 3 months is 2 centimeter per month, and then after next 1 centimeter per month, and for next 6 months it is 0.5 centimeter per month for next 6 months.
Okay, wonderful. So when do you say someone has macrocephaly?
When it is more than 2 standard deviation from the normal.
On the chart. Wonderful. Okay, so I'll stop it there. So what is the treatment for this patient? What would you like to do?
Treatment is VP shunt better, sir, because
VP shunt or ETV?
ETV, sir, less is low, sir.
It's 4 months.
Age is less, so ETV is not good for it. So better to do VP shunt, sir.
So which pressure VP shunt would you like to do? What is the wall pressure of the VP shunt to do? High?
Medium pressure, sir.
Okay, medium or low is good. I mean, people, there's a controversy as to like which one. Okay, I'll close it there. So I'm beyond my time. Yeah, I'm done, Dr. Manas. Hello, Dr. Manas. Dr. Sriram.
Sir, can you please stop sharing, sir?
Okay, I'm sorry. Yeah.
You are done, no?
Yeah, I'm done. Yeah, I mean, there are questions, but I'm much beyond my time. So.
No, you finished, I think, on, okay. Dr. Manas is not there?
No, I'm there. I'm there. Vamsi, thanks, Vamsi. And then I'd like to thank Dr. Vamsi, Dr. Chandan, Dr. Balamurugan, and Dr. Anita. I'd like a few comments from Dr. Muthukumar and Dr. Suchanda also. Dr. Muthukumar is in the line?
I'm here.
Yes.
It's good as usual. Like last time, it was good. The learning experience, very practical questions were asked. Maybe I think the time allotted for the candidate, is this the time that the DNB, is this the format that DNB follows, the time? I think a little more time was given to the candidates. Don't you think, Manas?
Extra time.
Yeah. So if you restrict the time and instead of asking them to write, this is just a suggestion because I'm used to teaching only MCH postgraduates, not DNB postgraduates. So this, if you are just ask them to answer, the faculty members will be able to ask more questions, you know.
Yeah.
So that will be that way. So quickly they can pass on to the next question, and they can also teach more.
Yeah, means the thing is like that is a simulation of a Viva Voice exam.
Okay.
In OSCE, they have to write practicing. So that is why you are giving the time.
Okay, fine.
In a Viva Voice pattern, I think 200 marks is that they have to write down, and in 100 marks is like Viva Voice where they can directly ask the questions. Because this is for the first time they're having. I am also not very clear on the pattern what they will have.
But I think the OSCE pattern is, of course, it's not possible to do it online. OSCE pattern, there will be multiple stations where the candidate will be taken, and then they'll be shown the case and this something like that, isn't it?
Yeah, no, but what they are doing for other departments is they project one screen only from Delhi, and and time is given 2 minutes, and then the next question comes.
Oh, from Delhi it is projected. Okay.
Yeah. Local people have no control.
Okay, fine.
The local is only like invigilation, but they have control on the 100 marks where they do 2 short case and all the Viva Voice and all those. 200 marks they don't have any control. Okay, Dr. Bala. Okay, he is an examiner. He'll know. Dr. Bala.
I am not yet an examiner, but my colleagues are examiners for National Board. And what they've been told is like what Dr. Manas said. So it's going to be, they'll be called to a center where it will be online. And there will be case scenarios which will be given. And a time frame is given for them to write down the answers. And then they are discussed. I think even MCH Neurosurgery this year in Ramchandra Medical College, the candidates were in Ramchandra, and online the examiners were from, I think, Stanley and Government General Hospital. They were in their respective hospitals, and online they just questioned the candidate on the case which was presented. But in National Board, I think it's only the case scenarios are given, and I don't think any case presentation is really happening in the other departments so far. What we have come across, even in pediatrics.
No, I think in Ramchandra this time that was done because of the COVID situation. Probably DNB has done it for good. DNB has done it for good, I think so.
Really?
What Dr. Rajesh was telling from Nizams, because he's one, they are also conducting exam. They said that in one of the DNB residents also put in chat box that they'll be given 5 minutes for each question, and each question is 8 marks. And each question has a separate answer sheet. Immediately after that, they have to give up that, and they take a new sheet. So not that they can go back and write down if they remember later.
Okay.
And this one, examiners are also coming actually.
Yeah.
Really?
From outside, outstation.
So what you should be knowing also.
But Susan, I said this DMP pattern has changed only now from this year, isn't it?
Yes. Because of this COVID.
It's only for COVID.
I think Ramchandra pattern also changed because of this COVID only. Otherwise, Ramchandra used to have the same pattern which was implemented in the rest of the medical colleges in Tamil Nadu and other state government medical colleges. This time Ramchandra was pattern changed because of the COVID situation.
I think this
asking pediatrics for DNB, they have been doing this for quite some time, not for COVID. It is there.
Yeah, pediatrics, it is going on for quite some time. This same pattern.
Pediatric surgery or general pediatrics?
General pediatrics.
Oh.
And there are some places that centers also where there can be a teaching center. I am aware of two, because in Kolkata where they are having coaching centers where they teach the students in the same pattern in the evening classes, something like that.
Oh my God, really?
So
they have coaching for this also? Huh?
Yeah, yes.
Coaching?
Yes, it's happening. It's there. I myself am aware of that.
NSI in BAS.
Huh?
This is like coaching class.
This is the NSA coaching class.
So before we go,
to give you her comments.
We will have Mr. Sriram, is the national anthem ready? If people are not well dressed, they can put off the video. But everybody has to stand. Is the national anthem?
Everybody has to stand only. Come on. Yes, when they switch on the.
Yeah, Mr. Sriram is ready.
I'm just coming, sir. 1 second.
Yeah. Supposed to play the.
So we are as well kind of changing the videos.
Huh? For all the students for participating and all the faculty for spending time in making the questions and conducting it very well today. And though it was a holiday, we still had a lot of participants. And from next, I wish all students best of luck for the exam. And next time onwards, we'll have once a month, the first Saturday of the month. And we'll alternate with case discussion and an OSCE pattern of exam. So that should be fine. But if you people have any feedback, please write or send a WhatsApp message so that we'll follow that changes if anything else you need. With this, I'd like to we'll meet again on first week of September. And thank you all and good night.
Thank you, sir. Thank you, sir.
Thank you, sir.
All the best, everyone.
Thank you,
madam.
Thank you, and all the best for the candidates.
All the best.
All the best,
candidates.
everyone. Yeah.